My name is Ariadna Polichuk and I represent Omega Kyiv Medical Group. And the topic of my presentation is CT volumetry of the liver. Volumetry is an important tool in multidisciplinary approach when the close communication between the surgeon and the radiologist is really essential in the determination and choice of surgical procedure. 3D imaging technique is useful in most liver resections. It improves the surgeon's knowledge of liver anatomy and makes even more complicated liver resection safe. Liver volume estimation is vital in pre- and post-operative evaluation of the patients undergoing liver resection or liver transplantation. Computed tomography volumetry allows us to obtain accurate measurements of the liver volume before and after surgery, which provides an assessment of future liver remnant or graft size as an important determinant for avoiding post-hepatectomy liver failure. By using this technique, we are able to detect liver lesions, their quantity, and especially lesion relations to underlying vessels and biliary ducts. Patient data. We had 131 patients underwent the computed tomography volumetry during 2016-2019 with the following characteristics. So we had 93 patients with metastatic liver tumors, 34 patients with primary liver tumors, included cholangiocarcinoma and hepatocellular carcinoma, and also there were 2 living donors and respectively 2 recipients. Data acquisition. Multi-detector CT scanner Philips Brilliance with 64 slices was used. All liver volumetries were reviewed on a workstation Philips IntelliSpace portal in the application CT liver analysis. The rigorous requirements to our protocol are next. It's multi-phase scanning with intravenous contrast injection with a speed 4-5 milliliters per second. Portovenous phase is always preferable with a good contrast enhancement and agent accumulation in hepatic venous and portal venous systems. There is a direct correlation between a good automatic vessel segmentation and intravenous iodinated contrast agent accumulation in the liver veins. Post-processing included calculation of total liver volume, tumor involvement volume, partial, sectional, and segmental volumetry, and also vessel segmentation with following 3D modeling. Also, percentage of future liver remnant before and after portal vein embolization. And there is a part of liver parenchyma that is not covered and not calculated. Later on, we are manually make our corrections like that. And here you can see the final result. All the parenchyma is covered and very well calculated. That's a 3D model. We call it batch. And in the right lower corner, you can see the total liver volume is already calculated. Step number 2 is automatic segmentation and classification of the portal and hepatic vessel trees. 2 venous systems are coded by different colors and very well separated. And vessel segmentation is also required for identification of portal vein anatomic ramification type, or maybe there is a determination of important hepatic venous abnormalities. That's a batch. As you see, the vessels and liver parenchyma are already calculated and segmented. Step number 3 is semi-automatic but mostly manual lesion segmentation with the following volume calculation. Here, that's the most human-dependent factor because we are defining all our lesions manually. That's how it looks on the axial slice. And then you can make any correction. You can make your definings bigger or smaller. And that's what we get after this. And we have already the volume of metastasis calculated. In the on the table below, you can see there are two volumes. It's functional liver volume and total liver volume. And from functional liver volume are already excluded the volumes of lesions and of segmented vessels. I wanted to say that all the segment model proposed by French surgeon Claude Quinault. And this model is approved by many liver surgeons in the world like a gold standard. In this model, every segment is an independent functional unit and it has its own dual vascular inflow, biliary and lymphatic drainages. Manual marking of anatomical landmarks is applied. Professor Valette from Lyon, France, and this method is based not only on the division of intrahepatic branches of the portal vein, but also utilizing certain ligament marks and hepatic veins for better and more accurate segmentation. On the left image, you can see the 8-segment model by Claude Quinault, and all the segments, as you see, are divided into that's why it's so important to know liver anatomy. We have 10 points for accurate segmentation. Point number 1, it's inferior vena cava, and it's a connecting point for all the others. Then it's right portal bifurcation, which horizontally divides the upper and lower segments. It's placed here, upper and lower segments of the right lobe. Point number 3, it's right hepatic vein, and it divides segment 7 from segment 8. Point number 4, it's middle hepatic vein, and it matches with Cantley's line, and it's a division of it's steep left liver, it's the margin of left lateral section. And then, as you see, we have 3 ligament marks. It's superior, superficial, and deep ligamentum venosum, and those are accurate borders of segment 1. After all the points are placed, on the Excel slides, you can see how it looks. Every segment is coded by different colors, as well as the metastasis here. And then 3D modeling. 3D modeling. So here, this step, it's our imagination. We can show it to us. Okay. Summary table. All needed measurements are already here. As you see, there is functional liver volume, total liver volume, routine. And then the last step, the last but not the least, it's pre-surgery planning, and it's a tool of virtual removing of one or a few segments which are damaged, with the following calculation of the remaining liver volume and resected volume. The volume of all measurements is reflected as a percentage. And And a surgeon doesn't have to remove the whole segment. He can remove just a part of it, just a few cubic centimeters, for preserve as much liver parenchyma as it's possible. And you can see the safety margin in yellow. And below there is a resection summary table with the volume of every segment, and then total resected and total remained parenchyma. One more picture. And then 3D modeling. As you see, the damaged parenchyma is already removed, and that what we see, the segments is remained parenchyma. Okay, results. On this point, a strategy of a surgery can be adopted with step-by-step planning. For example, when preoperative portal vein embolization is needed. All the patients after our volumetry and all necessary measurements were divided into several groups. Following re-estimation of resectability. And in group 3, we had 26 patients with post-portal vein embolization evaluation. Among them, we had 14 patients with sufficient future liver remnant hypertrophy, and they were considered resectable. 4 patients had insufficient hypertrophy, so subsequent follow-up needed. And unfortunately, 8 patients had shown tumor progression in the background of portal vein embolization, and they were considered unresectable. Take-home messages. Computer tomography volumetry, it's a very convincible method for performing all the necessary measurements according to its availability and reasonable price. Accurate knowledge of tumor location, vessel anatomy allows us to rationalize surgical treatment of the liver based on predict benefit and risk ratio in every particular case. And nowadays, when everyone is talking about artificial intelligence, even by having automatic and saving automatic soft, that's it. Thank you for your attention.